Good day, everybody, and welcome. My name is Lauren Paramour. I'm a lecturer in political studies at the University of Cape Town and a member of the People's Health Movement. This panel, entitled Governance for Health Towards More Equitable Policymaking and Health Partnerships, has been coordinated by the People's Health Movement and more specifically by Dr. Sulakshna Nandi, who is the co-chair of the People's Health Movement Global Secretariat. If you have any questions for our panelists, please drop them in the Q&A box below, and we'll discuss them after the panelists' presentations. I'm pleased to welcome our speakers, and I would like to thank them for making the time to contribute their insights on this topic. I'll introduce them now briefly, but I'll introduce them more fully just before their presentations. So a welcome to Dr. Peter Singer, Special Advisor to the DG of the World Health Organization, Dr. David McCoy, Professor of Global Public Health at Queen Mary University, London, Sasha Stevenson, who's head of Section 27, head of health at Section 27 in South Africa, and Dr. B. Iqbal, who is a member of the Kerala State Planning Board in India and also chairperson of the COVID Expert Committee of the Government of Kerala. So a brief note of introduction to the panel. In this webinar, we'll be assessing governance for health in the context of the COVID-19 pandemic. And we'll be discussing a way forward for more equitable policymaking and partnerships in the global and national governance contexts. With the outbreaks of the Ebola pandemic in 2014 and 2019, national governments and multilateral organizations' responses to the COVID-19 pandemic were questioned. And again, in the context of the COVID-19 pandemic, critical questions are being raised about the ability of existing global governance mechanisms to respond effectively to a global health crisis of this scale. This is intrinsically related to the nature of health governance that existed before the current pandemic. At an international level, there continues to be a mushrooming of global health partnerships that create more opportunities for non-state actors to participate in policy and program decision-making. Such partnerships can have positive health impacts, but there remain concerns that organizations representing for-profit corporate interests can exert greater influence, thanks to their deep financial pockets, than international NGOs that represent broader public interests. The increased engagement of established global institutions, notably those associated with the underfunded UN, with private sector organizations, including efforts to secure private sector partnership financing, has led some civil society organizations to caution that we are witnessing a slow privatization of global governance. In contrast, the power and expertise that grassroots organizations, local governments and municipalities, and frontline health workers, like community health workers, bring to bear on the pandemic, particularly in terms of contact tracing, health education, and psychosocial support, is not adequately recognized. In this pandemic, they've typically not been given a seat at the decision-making table, yet they tend to be called up to volunteer their labor in pandemic management efforts when the private sector or official government agencies become overwhelmed. In many countries, there's been a lack of transparency in policymaking, data sharing, and procurement during the pandemic. In some countries, there's been a push towards further privatization of health services, and some governments have turned to autocratic behavior, militarization of COVID-19 responses, and xenophobic and anti-scientific language to describe the pandemic. All of these measures risk eroding trust in governments and thereby fundamentally undermine public health efforts to contain the pandemic. At the global level, the retreat by some countries from multilateralism has created new challenges for health governance. And the pandemic is also raising old questions about the relationship between the WHO, which bears primary responsibility for governing global health, and other multilateral agencies that can be used to endorse laws and practices that have health impeding effects. For example, the World Trade Organization. So, to discuss these very complex issues, we now welcome our first speaker, Dr. Peter Singer. Dr. Peter Singer is Special Advisor to the Director General of the World Health Organization, Dr. Tedros, and also serves as Assistant Director General of the World Health Organization. In this role, he supports the Director General to transform WHO into an organization sharply focused on impact at the country level. Dr. Singer co-chaired the transition team, was architect of WHO's strategy and its triple billion target, works with colleagues to guide consistent strategy implementation of WHO's program budget, results framework, and first investment case, and provides leadership to the Secretariat of the Global Action Plan for Healthy Lives and Wellbeing to strengthen collaboration amongst 12 multilateral agencies to accelerate the health-related sustainable development goals. From 2008 to 2018, Dr. Singer was CEO of Grand Challenges Canada, and from 1996 to 2006, he was Sun Life Financial Chair and Director of the University of Toronto Joint Centre for Bioethics. He was also Professor of Medicine at the University of Toronto and Senior Scientist at University Health Network. In 2007, Dr. Singer received the Michael Smith Prize as Canada's Health Researcher of the Year in Population Health and Health Services. And in 2011, Dr. Singer was appointed Officer of the Order of Canada for his contributions to health research and bioethics, and for his dedication to improving the health of people in developing countries. He is a Fellow of the Royal Society of Canada, the Canadian Academy of Health Sciences, the U.S. National Academy of Medicine, and the Academy of Sciences for the Developing World. Welcome, Dr. Singer.
Thank you. Thank you so much. It's really great to be with the other panelists and with everyone listening. In the coming less than 15 minutes, I really want to explore this issue of governance, of ethical governance, and I have a very simple message, that in the context of COVID-19, we're seeing a dynamic governance, set of governance arrangements unfolding. I'll sketch the landscape of those arrangements. And let me just say up front that I think everyone recognizes the critical role of civil society, both global civil society, but especially civil society at the country level, in terms of participation in governance of the unfolding arrangements that I'll describe. So that's essentially my key message. And I'll describe a number of global arrangements. They're a bit like Anne-Marie Slaughter's version of governance and issues networks, a more dynamic version of governance than intergovernmental governance alone. I'll describe them, and then I think the other panelists will focus on country level governance. So I'm going to structure my remarks in 5 areas. One is, where are we now? And then the public health foundations of the response to COVID. Thirdly, the new scientific tools. Fourthly, the focus on recovery. And finally, some concluding remarks. So where are we now? We're at a point where there's 50 million confirmed cases since the beginning of the year. Sadly, 1.25 million people have died. We have incredible contributions and sacrifice on the part of health workers, who constitute 2 to 3% of the global population and 14% of the global COVID cases. In a sense, with cases rising in many parts of the world, this is a type of Churchillian moment, like in his famous 1940 speech about fighting on the beaches and we shall never surrender. I think WHO's played an incredibly important role, because global challenges require global solutions. And the value that we see underlying all this, and something Dr. Tedros has spoken about right from the beginning of the outbreak, is the value of solidarity. That value is very, very clear. On the governance side of this, where are we now question, is the established set of governance arrangements, the G7, the G20, the regional groupings, and the broader sets of governance arrangements in the world. And I won't delve into those in detail, since those are established. They certainly do have changing dynamics that I think were referenced by Lauren. But that's just a quick snapshot of where we are now. And before turning to where we're heading, I'd like to ask us all just to stop for a moment of silence to remember the more than 1 million people who've died, their families, their suffering, and also to respect and appreciate the contributions and, sadly, in some cases, the sacrifice of health workers and indeed all essential workers around the world. So if you could just join me just in a moment of silence, so we start our conversation in a highly respectful way. Thank you so much. So I've talked a little bit about where we are now, and really just want to emphasize that everything else I have to say rests on that bedrock of global solidarity, national unity, and everything else follows from that. And it's interesting to me that that's a type of soft infrastructure, if you will, of governance for everything else that follows. So then, where are we going based on that? Foundation? Well, the next area I'd like to cover is the public health foundations of the response, the public health fundamentals of the response. And WHO's advice really hasn't changed since January. The heart of WHO's advice has been about public health measures. It has been about testing, about finding the virus, about isolating cases, and of course, caring for them, tracing and quarantining contacts. That's the heart of the response. And countries that have been able to control the virus actually have used those methods. And the difference maker really between those countries, I think, that have done well and those that have done less well has been the extent to which they followed that kind of advice and frankly, WHO's advice. Of course, this is accompanied by broader measures, masking, physical distancing, and so on. And when necessary, when the virus runs out of control, the tamping down from more restrictive measures and so-called lockdowns really used as a last resort, not a first resort. And so these public health fundamentals are there. I think they're extremely important. They're going to be needed today. They're going to save lives until there's a vaccine, and they're going to save lives while there's a vaccine, and they're going to save lives after there are vaccines. And if you look at the governance side of these public health fundamentals, what you see is WHO's existing governance, and there's an ongoing discussion of the civil society engagement in that, which I won't delve into at the moment, and the UN crisis management team. And those are the governance arrangements of the public health fundamentals. The third area I'd like to touch upon then, having talked about where we're at now and where we're going in terms of the public health fundamentals, is the new scientific tools. And here I'd like to focus on the ACT Accelerator, whose aim, of course, is to accelerate the development of vaccines, drugs, and diagnostics, and importantly, to ensure their equitable distribution. The goal on vaccines, for example, is 2 billion doses by the end of 2021. And we did have some encouraging news yesterday from the Pfizer-BioNTech RNA vaccine and its early interim report of 90% efficacy. The issues here, for example, if we were just going to zero in on vaccines, are safety and efficacy. And WHO will only support or endorse a vaccine that it believes is safe and efficacious. Very importantly, the equitable distribution of vaccine. There's clear modeling that we save more lives by distributing the vaccine to some people in all countries rather than all people in some countries. And WHO's made an incredible effort, I think, in terms of the member states coming together last spring and saying that these new health technologies like vaccines were a global public good, and work on the equitable allocation framework. And then on top of the huge development effort, with more than 200 candidates in the pipeline, 45 in human trials, 10 in late stage human trials, on top of the safety and efficacy issues, on top of the equitable distribution issues. Of course, we have the distribution challenges and the huge logistic effort with innovation required to overcome bottlenecks. And the financing. At the moment, the ACT Accelerator, which is a partnership among several agencies, what it really needs is finance, an immediate need of $4.5 billion, which seems like a lot of money, but it's very small compared to the trillions that have been spent in stimulus spending and in economic damage. So flipping to the governance side, I think a robust discussion has been unfolding, inviting civil society to participate in the different pillars of the ACT Accelerator. I've seen firsthand Dr. Tedros encourage that discussion. I've seen the integration of civil society into different accelerators, pillars. So that's a set of governance arrangements that's there at the moment. Having talked about where we're at now, the public health foundations, the new scientific tools and the relevant governance arrangements related to them, I'd like to turn to issues of recovery. And it is a little early, to be honest, to focus very much on these, but I think it is important to talk about them. For me, these have a lot to do with a recommitment and expansion to primary health care, which of course is not only access to essential health services, including essential public health functions to prevent future outbreaks, but also empowerment of communities and multi-sectoral approaches. And this is essentially what the Astana framework says. In addition to primary health care, and actually primary health care itself has a very, very strong focus on equity and inequities. I think for me, one of the most important aspects of the COVID-19 response has been how it has been a very, very cruel unmasker of pre-existing structural inequities in our societies, how it's effectively preyed on those inequities. And I think the recovery has a lot to do with redressing those inequities. If I look at the governance side of this element of recovery, what I see is a very strong focus on multilateralism. That means the arrangements amongst multilateral agencies in health. And here I would reference the Global Action Plan for Health and Well-Being, Healthy Lives and Well-Being, the so-called SDG 3 Global Action Plan, which is a partnership among 12 multilateral agencies that are focused on health. And these are the agencies you would think of, led by WHO, including UN agencies like UNICEF, UN Women, UNDP, UNFPA, and others, and also agencies outside the UN system, like Global Fund, Gavi, Global Finance Facility for Every Woman, Every Child, World Bank, and others. So there is a civil society accelerator in the Global Action Plan for Healthy Lives and Well-Being. Civil Society and Communities Accelerator is one of the focal points alongside primary health care and so on. There's a strong focus on equity with the determinants and the Civil Society Accelerator coming together with the Gender Equality Working Group. Gender equality, by the way, cuts across the whole Global Action Plan. We acknowledged that the civil society engagement was something that we needed to focus on more strongly in the second year of the Global Action Plan. And there has been, I think, a more robust approach to that, thanks to some partners like a civil society advisory mechanism, like some NGOs that have really helped launch seminars to facilitate further engagement between GAP and civil society. And of course, where that has to lead is what I mentioned at the outset, which is civil society at the country level, because that's extremely important. In addition to multilateralism, as in the relationships among agencies, the relationships among countries and member states and governments is also an important aspect of multilateralism. Yesterday, in his speech to the World Health Assembly, Dr. Tedros essentially made a proposal based on an earlier idea proposed by the Central African Republic and Benin as co-chair of the African Union. And that proposal is the Universal Health and Preparedness Review. It's based on the Universal Periodic Review Mechanism used by the Human Rights Council. And its purpose is to build mutual trust and accountability for health by bringing nations together as neighbors to support a whole of government approach to strengthening national capacities for pandemic preparedness, universal health coverage, and the multi-sectoral approaches inherent in healthier populations. Dr. Tedros mentioned that WHO is in the process of developing a more detailed proposal, which it will share shortly. And so in summary, on this kind of recovery area, primary healthcare, a focus on equity, and the essential role of multilateralism in that domain, I referenced the Global Action Plan for Healthy Lives and Wellbeing and this new Universal Health and Preparedness Review Mechanism. In closing, I've covered and really sketched the global landscape, which is a dynamic landscape, I think, of governance mechanisms, some of which are quite purpose-driven, like the ACT Accelerator, some of which are broader and linked very closely to the SDGs. So they have a 2030 target and a much broader scope. I've talked about where we're at now, and the important value of solidarity in the G7, G20 governance groupings, the regional groupings, the public health foundations of the response, and issues in WHO's governance and issues in the UN country management, crisis management team, the new scientific tools, governance and civil society engagement related to the ACT Accelerator, the focus on recovery, with the Global Action Plan for Healthy Lives and Wellbeing and this new proposal on a Universal Health and Preparedness Review. And the last concept or last word I want to leave you with is hope. I started with solidarity and I want to end with hope. The only way that we're going to get through this pandemic and actually defeat COVID-19 is together. But I'm very hopeful that defeat it we will, defeat it we shall. The world overcame smallpox, which killed more people in the last century than all the wars combined, 300 million people. How did we do it? We did it together. And in this area of hope, in this area of togetherness, the voices of civil society will be critical, and especially the voices of young people, and especially civil society and young people at the country level. So with that, thank you so much for your attention, and really look forward to hearing the other panelists participating in the discussion period. And Lauren, thank you so much. Back to you.
Thank you very much, Dr. Singer, for that. The point you made about COVID unmasking pre-existing inequalities really struck me. And it makes me think of, this idea of solidarity as mutual aid towards a common purpose. And not disregarding the differences between the entities, the actors collaborating to achieve that common purpose, but acknowledging the different strengths and weaknesses of all the partners. So it will be interesting to see what happens in terms of relationship and trust building in the Universal Health and Preparedness Review mechanism that you mentioned. So perhaps a new model of governance emerging there. Thank you.
Thank you.
Thanks. Next, we turn to Dr. David McCoy, who is a professor of global public health at Queen Mary University, London. He's a qualified medical doctor and spent 6 years as a clinician in the UK and South Africa before entering a career in public health. He spent a further 7 years in South Africa working to support the post-apartheid transformation of South Africa's health system. And since returning to the UK, he's worked across the NGO sector, academia, and the NHS, including a period as Director of Public Health in London. Over to you, Dr. McCoy.
Thank you very much. I've got a presentation, so I'll share my screen. I'd like to begin by first thanking the People's Health Movement for inviting me to speak. For those who don't know the People's Health Movement, it's a loose network of individuals and organizations from all across the world that has, throughout its 20-year history, offered a platform for health activists, for academics and health professionals to hold onto the ideals of the Alma Ata Declaration, to highlight the political and ideological determinants of health and avoid the idea that we can achieve good public health with only technological solutions and charity, and to consistently challenge powerful invested interests on behalf of the general public. And I say this because these are the kinds of principles that give me hope in the face of the many challenges we face as a global community, including but not limited to COVID-19. And by extension, I want to thank the Thai health community for organizing PMAC every year and giving People's Health Movement a platform. Now, as well as mourning those who have lost their lives, as Peter has helped us do, I'd also like to pay tribute to the many, many public service and public interest scientists, professionals, and activists who've been working tirelessly since the beginning of the year to keep us safe, including those working in WHO itself. Now, before I speak to the title of my talk, I want to first acknowledge that COVID-19 is extremely difficult to control. Furthermore, the degree of susceptibility and vulnerability to the virus varies substantially from country to country for reasons that include differences in age structure, population size, and population density, difference in the prevalence of conditions like obesity, and probably differences in levels of pre-existing immune protection. Furthermore, because of the considerable collateral damage associated with lockdown measures, the performance of any country cannot be judged simply in terms of counts of the number of COVID infections and deaths. We need to judge countries in a much more holistic manner and over a longer period of time. And we need much more disaggregated data to examine the unfair and unequal distribution of harm. So in short, judging and comparing the performance of countries is not at all straightforward. However, I would say that it's possible to identify countries that have governed less or more effectively and less or more fairly. And for me, I have to say that it's rather difficult to escape the conclusion that the response to COVID-19 in the UK, but mainly in England, and less so in Scotland and the other devolved nations of the UK, it has been a sorry state of affairs that I have characterized in 5 ways. There's no question that the government was slow in responding to COVID and that the health system was underprepared for an acute pandemic, even though a pandemic has been consistently listed as a major threat on the government's national risk register. Some of the slowness was the result of complacency and arrogance, which led to a non-recognition of the threat posed by the virus, as well as mistakes that were made in the modeling of the pandemic. But the unpreparedness was also the result of years of austerity and underfunding of the health system and the adoption of a flawed market logic that effectively devalued public safety. But when the government finally swung into action in March, it created an over-centralized and disintegrated approach to transmission control that was unfit for purpose. Instead of creating a system, we ended up with a shambles. The response was furthermore commercialized and, in my view, corrupt. During the intensive lockdown period, when we should have used a rapidly expanded health budget to build an effective testing and tracing system, we saw multiple private for-profit companies with no public health experience, expertise, or credibility being awarded huge contracts to deliver on critical public health interventions with minimal transparency and little accountability. Now, I don't know if this fits a legal definition of corruption, but only yesterday, the Guardian newspaper reported that a campaign group, along with a cross-party group of parliamentary MPs, is taking the health secretary to court, claiming an egregious and widespread failure to comply with legal duties and established policies. But regardless of whether any laws were broken, there's no question that the public health system has been corrupted and that there's also been a moral corruption of various sorts. The fourth characteristic of the UK response to COVID was that there was a marginalization of people and organizations with practical expertise and experience in communicable disease control. Instead, we ended up with the wrong people, with the wrong qualities leading the response to COVID. And finally, I would say that the government has behaved in ways that eroded possibly the most important ingredient in any pandemic, which is public trust in the authorities. Instead, we had a government that adopted a style of communication that was patronizing, dominated by spin, and reassurances to the general public that were regularly found to have been false. We saw the Prime Minister's special advisor excused for breaking the rules of lockdown while he was clearly being economical with the truth. And we saw ministers refuse to apologize for the lack of personal protective equipment in hospitals and social care homes. And there was also, in my view, a huge overemphasis on the use of technological solutions such as mobile apps, which was indicative of a reluctance to acknowledge the social dimension of the pandemic and of the importance of working with communities and local municipalities as partners. Now, I want to describe the test and tracing system in a bit more detail to illustrate some of these characteristics. In fact, one of the major design flaws in the response to COVID was to treat testing and contact tracing as separate and centralized programs operating with parallel management structures and systems. There was also no strategy for deploying the limited testing capacity in a smart and tactical way. And instead, testing quickly became a simplistic numbers game. It was all about how many tests we did, rather than about thinking about the strategic value of testing and its effectiveness. Now, to make matters worse, the government also decided to commercialize and privatize these core public health functions. With testing, big contracts were handed over to corporations such as Serco and Deloitte, and similarly with contact tracing, big contracts were handed over to the corporate sector, who deployed a centralized system of poorly paid call handlers with no relevant background or experience. And to make the system even more fragmented, these main contractees of the contact tracing system subcontracted other companies to deliver contact tracing, including a travel company and a debt collector. So what we had was not just fragmentation within the testing system and fragmentation within the contact tracing system, but we also had various disconnects between testing and contact tracing. Now, many people were wondering, where was the National Public Health Agency in all of this? And Public Health England was given the job of running contact tracing, but only limited to hospitals and care homes. And it was given little authority and provided little leadership. And indeed, Public Health England is now being abolished to be replaced by an entirely new agency in the middle of a pandemic. At the same time, local authority public health departments and primary care GPs were being marginalized and ignored for months. Similarly, instead of building up the existing laboratory capacity in hospitals and universities, the approach to scaling up laboratory capacity was characterized similarly by centralization and commercialization. And this general disorganization, coupled with the marginalization of local public health departments and GP practices, contributed to the failure to adequately protect the most vulnerable members of society in nursing and social care homes and the mainly poor people who live and work in unsafe settings. Now, meanwhile, in the hospital sector, another story was unfolding. Vast amounts of public money have been diverted to the for-profit private hospital sector with little transparency and scrutiny. This is a story that is currently being tracked by the Centre for Health and the Public Interest, the only health think tank in the UK that is entirely independent of government and the corporate sector, and which produced a report in 2013 which predicted much of the underpreparedness that we experienced when we faced COVID. Now,
Sorry, David, just to flag, you have 5 minutes left.
Thank you. I've only got 3 more points to make. Last week's PMAC seminar on the social determinants of health was very important in reminding everybody about the fact that while the virus is pathological and virulent, we also need to focus our attention on the social and political pathologies that accentuate the harms of both the virus and the collateral damage of lockdown measures. These include the kind of poor governance that I've just described, but also the commercialized health systems with ineffective regulation, the social inequalities that Peter talked about, and also the epidemic of misinformation and social polarization that's being whipped up on social media. And I've been reminded of the quote from the report of the Commission on the Social Determinants of Health about the causes, the underlying causes of the unequal distribution of health damaging experiences. The second point that I want to make is that we must avoid creating more social and political pathology in our efforts to control the virus. This includes inadvertently enabling greater degrees of surveillance and authoritarianism, a real danger given the rise in populism that we've seen over the last few years, further widening structural inequalities in society, including through the handing over of power to unaccountable and powerful corporations. Quite simply, there are good and there are bad ways to respond to this pandemic, both at the national level, but also at the global level. And by way of illustrating the latter, I'd like to draw people's attention to two recent articles about the role of the Gates Foundation in the pandemic, which highlight a number of worrying issues related to a lack of transparency and accountability of the foundation, their defense of corporate monopolies, the stifling of real debate in civil society over hard choices that need to be made, the balance between public and private interests and the balance between the needs of developing countries and the interests of developed economies. Now, my final point is going to be more upbeat. As we know from the Japanese construction of the word crisis, COVID-19 should be seen as both a threat and an opportunity to correct the social pathologies of society. And to this effect, we must not just call out bad governance when we see it, but we must also celebrate good governance wherever it exists. And with that, I'll end and say thank you.
Thanks, David. And thanks in particular for putting on the table the question of whether or not we need a social vaccine for the many social and political pathologies that COVID-19 has revealed, the pre-existing pathologies that it's revealed, and also the question of how to evaluate COVID responses. So how do we take a holistic view and have a method of evaluation that looks at the multiple dimensions of the crisis, so political marginalization, oppression, access to basic things like water and sanitation, which also help to prevent the pandemic from spreading, but which can't be captured when you look at a metric like how many people have been infected or died. So thank you very much for that. I'm going to hand over shortly to Sasha Stevenson, who is an attorney and head of health at Section 27, where she leads a team of lawyers, activists, and researchers in the Health Rights Program. So Section 27 is a public interest law organization here in South Africa, where I also am, and it uses the law to catalyze social change. Prior to joining Section 27, she worked at a commercial law firm as a clerk for the Chief Justice at the Constitutional Court of South Africa and at the International Criminal Court in The Hague. Sasha holds degrees from Rhodes University in South Africa and the University of Cambridge in the UK. Sasha, over to you.
Thank you, Lauren. And thank you. trying to get this to work. Thank you so much to PHM for the invitation to join this panel today. Section 27 and PHM are close partners in South Africa, and it's great to be able to join a discussion that really, I think, draws the links between different country responses and global responses, and importantly, the role and shortcomings and difficulties of civil society generally and in relation to the pandemic. And so I'm going to be talking quite specifically about the South African experience and how we saw our role change quite dramatically as civil society during the pandemic, and what I think that teaches us for health system reform proposals moving forward. So South Africa's civil society has historically been strong and influential. We've had a number of really important wins as civil society over the years. The antiretroviral program, which is the largest in the world, was put in place because of the struggles and the advocacy and indeed the litigation of civil society actors. We have an intellectual property policy that was developed last year, and that we are awaiting conversion into amendment to IP law, that really forefronts public health and places great importance and highlights the importance of not allowing IP considerations to outweigh public health considerations. And that focus of the IP policy was really primarily as a result of civil society engagement and involvement. We have ongoing quality and facility monitoring that happens through civil society. And because of civil society's links with academia in the country and abroad, we're able to bring scholarship into our advocacy and therefore into policy making. So we've always had a strong civil society in the country, or we have for the last 25 years in relation to health and before that more generally. And we've also got institutionalized participation of civil society in decision making. So one of the really important structures that we have are AIDS councils, which operate at national, provincial, local, and very kind of ground level. And those are structures that are primarily civil society led, but that include people from government and academia and elsewhere. And really, they go beyond AIDS, they go beyond HIV, they're spaces for people to discuss and advocate about health systems and health systems changes and the circumstances within communities. And as I say, they exist at all of these different levels. Through public interest litigation, our courts have developed jurisprudence on meaningful engagement in decision-making, ensuring that people who are affected by government decisions are meaningfully engaged about those decisions, and that they can challenge the decisions based on a lack of meaningful engagement. So that gives both process rights to people, and it also gives people substantive rights within those processes. We then also have public participation processes in lawmaking. There's a requirement for comments to be solicited, and that oral submissions can be made within Parliament as well. And we have a general recognition within government of the rights-based mandate of health-related civil society. So it was within this context that we entered the COVID pandemic. And what did we see when we got there? Well, we saw a real shutdown of the usual processes of participation. Government closed up. They stopped relying on the kind of structures and processes that we ordinarily deal with. New structures were introduced, and those new structures had different players. And so rather than having AIDS councils informing local, provincial and national governments about what was needed on the ground, what people were thinking and how health systems needed to be adapted to respond to COVID, we had a health advisory body within the presidency that was led by the head of a pharmaceutical manufacturer, that included someone from a big medical scheme within the country. And so it was completely dominated by the private sector. And instead of having and that structure then became the dominant voice in the ear of government and publicly. And communication just stopped. Whereas ordinarily we would be able to correspond with government, to put forward proposals, to have responses, we just got no responses as civil society to our engagements over a number of months. And so while we would have thought that we would be in a good position in responding to COVID for civil society or civil society's involvement in the response to COVID, we found ourselves very much on the outside. And so what did we do? Right from the very beginning, from early March 2020, a group of what turned out to be over 200 civil society organizations, including community structures and trade unions, movements, NGOs, public interest litigation firms, faith-based organizations, got together to form the C19 People's Coalition. The primary call of the coalition was for a COVID response that's rooted in solidarity and equity, and that recognizes the South African context in any response to COVID. The coalition had a number of working groups, including health, anti-repression, basic needs, education, food, the economy, and many more. And each of these working groups developed their own mandate. And so what were some of the outcomes or successes of the C19 coalition and its members? Well, I think there were a number of important successes which relate in some way to health governance and health systems governance, but in other ways show the power of civil society even when it's sitting very much outside of the system. So the first was a case that the organization I work for, Section 27, together with the Equal Education Law Center, representing an education NGO called Equal Education and 2 school governing bodies, brought against government, requiring government to restart the National School Nutrition Program, which feeds 9.6 million children every day in the poorest 60% of schools, but which was stopped as a result of the COVID lockdown. And the litigation was successful. We got a judgment requiring that feeding starts again and that there's ongoing report back. And the latest report back suggests that 8.4 million children are now being fed under the program. So that was one of the successes of the period. A really important success related to the extension of the social security system. There was a big campaign led by civil society and supported by economists, activists, academics, and people within government, importantly, to increase child support grant and to provide a COVID grant for people who weren't otherwise recipients of social security. And this was, of course, important because South Africa started with a very hard lockdown for 5 weeks, starting at the end of March, which essentially shut down the economy and resulted in huge financial losses broadly and on an individual basis. And this call was successful, and there was the provision of a COVID grant to people who don't usually get social security, and the extension of a caregiver's grant to people who are looking after children. Another success was in relation to a campaign against regressive or repressive conditions at a temporary homeless shelter in Cape Town that forced the closure of the shelter and the provision of alternative accommodation. Like many successes, there were problems here, but it was an important step forward in recognizing the need to protect the dignity of people who had been moved into this inappropriate shelter. There was also a coalescence of a lot of advocacy on community health workers, an issue that gets fought for across the world, but that in South Africa has been fought in silos. And I think there was a great, as I say, a coalescence of that activism, which had some successes and I think has promise for the future. There was the collation of learning resources for learners who weren't at school during lockdown, so that they would be able to easily access online resources to learn by themselves. Very importantly, in response to pressure by civil society, there was a statement that access to abortion services would be considered to be essential services during lockdown and therefore must continue to be provided even as other health services were withdrawn or cut down. There was the establishment for the first time of a public interest law call line that people could contact and could then make referrals to organizations within the public interest law sector on issues within their mandate, a first and something that we will, I'm sure, continue. There was the establishment of communications campaigns led by civil society and in all of the official languages, and to make sure that people understood the message and that the message got out to constituencies. So those were, I think, some of the successes of civil society during the period, but what you'll notice is that many of them are from the outside, and they're not necessarily health governance successes. And I think that's because we were very much outside during the COVID-19 lockdown, and that we had been replaced by private interests in many cases. What we saw, and this mirrors something that one of the attendees said in the chat, was that there was a real lack of integration of the COVID program with other programs. We saw testing and treatment rates for HIV and TB go down. We saw the immunization program suffer. We saw expectant mothers not attending their antenatal care because they were worried about accessing services or were told that they shouldn't be going into clinics. And so that, of course, is ridiculous and is contrary to everything that civil society was saying, and I think really shows the need to incorporate civil society within these governance networks or mechanisms so that they can be informed by the real needs on the ground, and that health systems can be strengthened. And what we also saw, and I think in some ways this can be attributed to civil society being on the outside and not being able to participate in decision making and see at the time decisions that have been made, is masses of corruption and mismanagement related to PPE and other things. And this is still being uncovered, and it has to be uncovered through law enforcement and through investigative journalism, because the watchdogs weren't inside the system. So what do we learn from this? South Africa is moving towards a universal health coverage system that we call national health insurance. And we have been reflecting for a while on what the role of different actors should be within the system and what the governance mechanism should look like. What the COVID experience has shown us is that even institutionalized participation and accepted norms and oversight can be undermined when there is an emergency or when there is a reason to turn in a different direction. It's shown us that we can make impact from the outside, but our role from within the system is so vital. And I think what it's shown us most of all, and this confirms our advocacy in relation to universal health coverage, is that civil society in South Africa needs to redouble its efforts to ensure better health governance, to make sure that the structures within national health insurance and the health system in general are not centralized in the way that is currently envisaged in the bill, where the Minister of Health essentially makes all decisions at the top in relation to appointments to the fund, and that advisory committees are completely exclude civil society other than in one stakeholder advisory committee that has no role, but all of the other advisory committees don't include anyone from civil society. So that's something we need to focus on. We need to ensure that there's transparency so that we can see the decisions that are being made as they're being made, rather than having to rely on law enforcement and investigative journalism. We need to be able to participate in decisions that are being made in relation to funding and in relation to services provided. And we need to continue in our drive for accountability for the individuals and the structures that fail us, that have failed us during COVID, and if we're not careful, will fail us in our move towards national health insurance. Thank you.
Thanks, Sasha. I think your talk really illustrates the importance of institutionalized participation by civil society, but also prior to that, a well-organized civil society. So if people aren't organized prior to the crisis, then it makes it so much difficult to respond in the midst of the crisis. But also the ambivalence around participation mechanisms. So who creates them, who gets invited to participate, and on what terms. So I think those are all really important aspects of the COVID governance. that we need to take on board. So thank you. Okay. So next we have Dr. B. Iqbal joining us. He is the chairperson of the COVID Expert Committee of the Government of Kerala and also a member of the Kerala State Planning Board. He is the joint convener of JSA, People's Health Movement India, and also a former professor of neurosurgery and former vice chancellor at the University of Kerala. Welcome, Professor.
Good evening, and I'm indeed extremely happy to be with you and to participate in this very relevant and important and appropriate webinar on COVID-19 being organized by the Prince Mahidol Award Conference along with the People's Health Movement. In fact, I am, along with Sulakshana Nandi, I am also active in the People's Health Movement in India, the Jana Swasthya Abhiyan. In fact, the topic suggested to me was the role system of local governance in containing the pandemic. In fact, I have added the self here, local self-governance, because in many countries, local governance means that the local government institutions will be implementing the policies that are decided by the higher levels of governance. So therefore, I have changed this topic to local self-governments. In local self-government, the local governance systems have the autonomy to respond to the aspirations of the people down below instead of implementing the policies that are decided at the upper levels of governance. Now, I will be focusing on our experience in the Kerala state of India about the role of local self-government institutions in containing COVID. Now, as you know, the state of Kerala is the southern state in the India, one of the 28 states of India. We have 28 states and 9 central government governing places, and the Kerala state is divided into 14 districts. I am actually sitting in Thiruvananthapuram, the southern districts of Kerala. Now, the Kerala has got a lot of uniqueness compared to other Indian states in its demography and other parameters. Our Human Development Index is one of the highest in our country, not only in our country but also compared to many of the parts of the developing part of the world. The population size is 36 million. The sex ratio is 1084 in favor of female. That is to say, there are 1084 females for 1000 males in our state. This is because of the lower mortality rate among the females, also because of the high literacy rate among the females, and also because of their socio-economic freedom. The literacy rate is very high, and if you look at the life expectancy of female is higher than that of the males. They have about 5 years advantage over males. The crude death rate is almost on par with that of developed countries, 5.8 only. The infant mortality rate is as low as 7 compared to 29.8 of the national average. And the maternal mortality is only 42 compared to 113 of the national average. Now, when the COVID cases were reported first in India, in Kerala, in India, because 3 students from the Wuhan came back to Kerala in January 30th, and one of them was detected COVID. That was in January 30th. So, but we were aware that Kerala had certain challenges when COVID comes to Kerala, because the density of population in Kerala is highest compared to national average. National average is only 382, whereas the density of population in Kerala is as high as 859. There are only 2 states, West Bengal and Bihar, where the density of population is more than that of Kerala. And more important is that and therefore, since the R0 value of COVID is very high, 3 to 4, in a state where the density of population is very high, the possibility of transmission will be also very high. We were aware of that, and therefore we were well prepared to receive COVID when it comes to Kerala. And the elderly population is also very high. 15% of the people are above 60 years, out of which 11% are above 80 years. It is almost comparable to some of the Western countries. And it comes to about 5 million people are above of this risk group. And another major challenge we face here when COVID came to Kerala is that the comorbidity is very high. It's a highly morbid state. The non-communicable disease incidence is very high. Diabetes, about 20% of the people are suffering from diabetes. In fact, Kerala is called the diabetic capital of India. 33% of the people are suffering from hypertension. About 60,000 people cases of cancer reported every case. At a time, there are 200,000 persons with cancer in Kerala. 25 lakhs of people are suffering from respiratory infections. So the morbidity is very high. And we know that the mortality is high in the elderly population and those with morbidity. And therefore, in Kerala, there was a likelihood of high mortality because of COVID. And we had a very large migrant population also. The 3 million migrant persons from West Bengal, Bihar are also serving in Kerala. So therefore, you see that Kerala had a lot of challenges to face COVID, and we were very well prepared for that. Now, as on I will tell you, just mention about the current situation is that we had about 48,6109 cases as on today. Recovery rate is fairly high, 82.8%. And the active cases are only 16.8 of the total number of cases detected so far. But the more important thing is that the mortality, only 1,692 people died, and the mortality rate is as low as 0.35%, one of the lowest mortality, even if you take other countries of the world. Of course, the national mortality also is relatively low, 1.49%. In fact, one of the uniqueness of Kerala management of COVID is that we offer free treatment and testing to all patients, all COVID patients in our state in the government hospitals. Only free treatment and testing. Maybe only 1 or 2% of the persons are being treated in the private sector, but the hospital charges are fixed by the government so that they cannot be overcharged in Kerala. Now, the advantage of Kerala in managing COVID are because of two factors. One is that we have a robust public health system, and secondly, we have a very vibrant local self-government institutions. The robust public health system, when the present government came to power in 2016, and we have started what is called Ardra mission. Ardra means compassion. A compassion mission was started by which we are providing infrastructure and human resources to health institutions from primary healthcare centers up to the super specialty medical college hospitals. The primary health care centers are being converted into people-friendly family health centers. The number of working hours have increased from 2 o'clock to 6 o'clock. Number of doctors have increased from 2 to 3 and nurses from 3 to 4. And all essential drugs are provided even at the lower level of healthcare institutions. And the local self-government institutions have decentralized form of health delivery system, and which ensures community participation. And moreover, we have two experiences recently. One is a Nipah incident in 2018. 22 persons suffered from Nipah, and of which 17 persons died. And one case was reported in 19. And we had very severe flood in 2017-18 and recently in 2019 also. In these two experiences, the local self-government institutions' intervention was very effective in controlling Nipah on the one hand, also in preventing the infectious diseases which are usually seen following flood situations. So these experience also helped us in managing COVID. Now, the decentralization in India has a history of its own. The father of the nation, Mahatma Gandhi, used to talk about Grama Swaraj. Grama Swaraj means self-reliant villages. In fact, he used to say that India live in villages. And by the 73rd and 74th Constitutional Amendment Bill, a Panchayati Raj institutions came into existence in 1995. And there are 5 layers of local self-government institutions. The Grama Panchayat, this is the situation in Kerala now. The Grama Panchayat, the block and district panchayats, and the urban centers are the municipalities and corporations. So there are 2,400 local self-government institutions that have come to power. And as per the constitution amendment, 1/3 of the members of the local self-government institutions, functionaries will be women. But in Kerala, the Kerala government has decided that 50% of the local self-government elected representatives are now ladies. Now, when the decentralization came to Kerala, we started what is called the People's Campaign for Decentralized Planning in 1996. In fact, it was initiated in the state planning board. I was also a member of the state planning board at that time also, because the constitution amendment bill gave administrative decentralization. That is 17 institutions and 127 responsibilities were handed over to the local self-government institutions. But added on to it, we also decentralized financing and planning. That is to say that the state budget, now in the state budget, we allocate 26% of the state budget is allocated to the local self-government institutions. And also they can spend this 26% according to the people's aspirations at the lower level. And so they are given the responsibility of planning at the lower level also. This planning is done with expert assisted grassroots level planning, because large number of expertise is available in Kerala, because the retired experts and also those who are coming from outside India are part of the voluntary technical corps who advise the local self-government institutions in doing local planning, and also they develop the skill development of the local level functioning. And more important is that we ensure community participation. In fact, today Sasha Stevenson was mentioning about civil society participation. We call it community participation using the social capital, which is already available in India. So up to district hospitals are transferred to the local self-government institutions, and the Ministry of Health supplies drugs, equipments, and implement the vertical programs of the central government. But the local self-government institutions does the gap filling in drug supply, personnel, and materials. And they also ensure community participation. In this consent, I would like to remind you of a very important document by World Health Organization. World Health Organization said in the 1991 document that to improve the healthcare in the developing countries, decentralization of health services is essential. And by decentralization, they meant decentralization of planning, management, and budgeting. That is exactly what we did in Kerala. Now,
Dr. Iqbal, apologies, just to note you have 3 minutes left.
What did you say?
I said just to note you have 3 minutes left.
Okay. Now, when you come to COVID management, this is the strategy we follow: screening, testing, treatment, contact tracing, home and institutional quarantine, reverse quarantine of the risk groups, break the chain campaign, that is masking, hand washing, and social distancing, and COVID hospital, COVID second line treatment center, first line treatment center, and home care. All these, those that are shown here in blue letters are done by the local self-government institutions. This is the most important thing. Because of the reverse quarantine of the risk group, we could bring down the mortality rate in Kerala. Now, this is the social capital in Kerala. We have the self-help group of women below poverty line, about 4 million. There are preschool care, Anganwadi teachers, the ASHA workers, the people-friendly police, volunteers, youth organizations, people science movement, political movements, philanthropic and charity movements. All these organizations, with the civil society organizations, are joined together and they are linked together by the local self-government institutions to control the COVID. Now, and the protection of the marginalized is also important, because COVID is not only a health problem, it is a socio-economic problem. So during lockdown, the local self-government institutions started the community kitchens, providing food for about 200,000 to 300,000 people. The welfare pensions by the government were distributed by the local self-government institutions. The guest workers, these are the migrant workers, we call them guest workers, were provided with the stay facilities and food by the local self-government institutions. So now this is the current challenge we are facing, because COVID has come in early January and about 10 months have passed. So some amount of fatigue and burning out is happening in the healthcare workers especially. and some laxity in following masking and hand washing and social distancing. And post-COVID syndromes are coming up, but we have started post-COVID clinics and telemedicine to protect them. And there is a spiritual pilgrimage that is going to take place in November, December, and January, where crowding can happen, which can result in super spread events. In fact, the local bodies have come to power in 2015, and the elections are to take place now in December. And now, tomorrow onwards, the local body representatives' term is over, and therefore the bureaucrats will take over. But we have formed the people's committees to look after local self-government institutions. This is currently what we are facing now. In short, the message here is that we have a very well-functioning, vibrant local self-government institutions, and the local self-government institutions, by tapping on the social capital of Kerala, is trying to control, along with the health department, is controlling the COVID fairly well, and therefore we could bring down the mortality and morbidity in Kerala. Thank you very much.
Thank you, Dr. Iqbal. I think, especially thinking about the pandemic as something that's experienced by people in specific communities, this emphasis on local self-governance really resonates. But what struck me also is that there's a level of financial autonomy that these self-governments have, which I think is really, really crucial. Thank you very much. So I'm going to invite all the panelists to turn on their microphones and their cameras. And we're now going to open the discussion to a Q&A session. So perhaps just as an opening question, we're of course living through the COVID-19 pandemic, but there's another pandemic that we're living through that's still very much with us, and that's of course the HIV/AIDS pandemic, which is not over. There's no vaccine. There is effective treatment for HIV/AIDS, but my question to you would be, if you think about the HIV/AIDS pandemic and the lessons for governance that it's offered, those would be lessons like use a human rights approach, include the affected communities in all processes, ensure that essential medications are public goods, not for-profit commodities, essentially. So those would be the lessons of the HIV/AIDS epidemic. In another 30 years' time, if we're looking back on the COVID-19 pandemic, what would be the key lessons regarding good governance that you would hope would emerge from this pandemic? And this is maybe linked to David's idea of, how do we think of metrics that evaluate more than just our efficacy in avoiding mortality? What are the metrics we should be looking at to assess the efficacy and fairness of governance as a whole in this context, in the context of this pandemic? So I leave it to you to decide who goes first. Perhaps David, if you want to start, since you measured, excuse me, you mentioned the issue of how do we measure our success, so to speak?
Yeah, I think there's lots of parallels with HIV/AIDS, which haven't perhaps been fully unpacked. But one of the things that I've noticed is a kind of repeat of the kind of vertical approach to the disease, which can have the effect of neglecting these kind of wider pathologies. And this is to some extent kind of understandable. This is an acute pandemic. It's a very visible threat to health. But somehow we also have to pay attention to the more invisible threats to health, the various epidemics that are much more slow moving, much more chronic. And I would say that there are other kind of viruses in society that we need to think about. And perhaps one of them is the way in which we have systems that allow for the continued concentration of power and wealth, both at the global level and at the national level. And this inequality is really a virus that undermines democracy and that undermines the effectiveness of our public services and public institutions.
Thanks, David. Would anyone else care to take on this question? Maybe Peter, from a global perspective?
Sure. Thank you. Thank you, Lauren. Yesterday, Dr. Tedros addressed the World Health Assembly, and I mentioned the proposal on universal health and preparedness review. I think it's really worth looking at his speech. Towards the end, he essentially said this. He said, look, in 2015, there was a lot of hope and optimism. We had the SDG commitments by governments. We had the Paris climate conference. We had the Financing for Development conference that he himself chaired. They were all converging. We were dealing with these serious global issues together. And essentially, he said that thread seemed to have frayed over the past period of time, including with some of the challenges to solidarity in the multilateral system. And he called for forging a new era, really, of global cooperation that put health at the center and that had a very, very strong focus on inequality and redressing inequality. And here I'm really converging with what David was saying. And so from a global perspective, I think that's what it looks like. The other things I mentioned, the Global Action Plan, the Universal Health and Preparedness Review, those are important instrumental aspects. But soaring above that is really a spirit of global cooperation. And the way that COVID has really shown and elevated the importance of inequities. So for me, the potential opportunity in this enormous tragedy is, is it similar to when we came out of the Great Depression, when the United States came out of the Great Depression, and FDR's New Deal with elevating the focus on inequalities and social programs? I don't know if you think that's a useful analogy or not, but there is, I think, an opportunity to pursue the type of path that in Dr. Tedros' call for action that I just recounted. And I do think that has inequalities at the heart of it. And I think the most prominent thing about COVID is how it has really unmasked, preyed upon, and exploited the inequalities among countries, but I would say especially within countries. And so, Lauren, that would be my focus on where we could go forward. And maybe some of those lessons are also the same ones that one draws from HIV/AIDS.
Thank you. So I have a question for Dr. Iqbal and Sasha. One of the things that struck me about your presentations was that the private sector, Sasha, was very present in your presentation on the South African context. And Dr. Iqbal, in your presentation, it was almost completely absent. So I wonder, perhaps starting with you, Dr. Iqbal, if you could give a sense of the role of the for-profit private sector in the Kerala state's governance efforts, if it's been present at all. And also, Sasha, with respect to the South African context, clearly the private sector was present. So if you could speak to steps that were taken or could be taken to mitigate possible negative influences of private sector participation or for-profit private sector participation in COVID-19 governance. So, Dr. Iqbal.
Now, in Kerala, the public health coverage was as low as 28% in 1996 when the local self-government was about to take over. But the last figure shows that about 48% of the total health coverage is taken over by the public health institutions. And they are very vibrant now, very, very robust now. Now, when COVID came, our public health institutions started the COVID hospitals, COVID first line treatment center, COVID second line treatment center, and also those patients who are having only asymptomatic positive cases were managed at home. And they were taken care of by the local self-government institutions. So as on today, all the most of the, except 1 or 2%, all the cases are being treated in the public hospital. We have the facilities for that. In fact, we have the in the COVID hospitals, we have enough ventilators, we have enough doctors, nurses, etc., to take care of them. And but we have a cooperation from the private sector. In that, now the 45% of the testing is done and in the private sector. This testing is mostly done prior to surgical procedures, because before surgery, most of these patients are subjected to testing. But the fees for this testing is fixed by the government, so they cannot overcharge. Even some of the patients who are being treated in the private hospitals, the ICU care and the general ward care, etc., fees are fixed by the government. So it is functioning fairly well. I think the uniqueness of the Kerala experience is that we are offering, including food, is offered free to all patients here for COVID cases. But I have a question to David McCoy. In fact, I was a bit depressed to hear. What happened to your National Health Services? We were all trying to emulate National Health Services. So in fact, our the Ardhra mission, which I referred to, we are trying to build up our lower level hospital in tune with the NHS hospitals in UK. And we always talked about the NHS experience in UK. But what happened to NHS? Why is that NHS failed?
Well, I mean, I would say that the NHS didn't fail. And in fact, there's huge appreciation in the public for the work and sacrifice of NHS doctors and nurses and all of the other professionals working in the health system. What has failed is the government's support of the NHS. In fact, what I described as this bailout of the private sector hospital industry really represents a betrayal of those frontline health workers that put their lives at risk and that worked so hard to protect the general public. So in many respects, what we have is the remains of an NHS that continues to work in an amazingly efficient, effective and fair manner. But we have various other actors that are seeking to destabilize it and undermine.
Dr. David, I may tell you that in our local language, we have a lot of books being published in Malayalam. I am thinking of publishing a life biography of Anurin Biwan. In fact, I am collecting books on him. Yeah.
Okay.
I will send you a copy.
Sasha?
Yeah, so I think in relation to the private sector and how we manage private sector influence and for-profit private sector influence in South Africa. South Africa has a strange health system in that about 14% of the population receives healthcare services in the private sector and 86% in the public sector. And yet the amount of money that is spent on the public and the private sector is the same. So about half of health funding ends up in private, half ends up in public. And so, it's just baked in inequity. We have a very well financed and resourced private sector. And it's interesting that when push comes to shove, and despite the rhetoric and despite some kind of tussles between public and private in the past, when push comes to shove, government trusts the private sector more than it trusts civil society and health to influence decision making, and that's where they turn. I think moving forward, the way that we need to mitigate some of the negative potential influence of private sector, and this is so important for us in moving towards a contracting system where health services will be contracted from the private sector for public sector patients, is through regulation. The reason our private sector has grown so powerful for so long is because we've not been properly regulating it, and we've been waiting for national health insurance to come and solve all problems. We put a huge amount of money into an investigation into the private sector, hundreds of millions of rand. It came up with really important and good recommendations for regulation of the private sector, and we've seen absolutely no movement on that because it's government's view that through monopsony power and contracting, we'll be able to just deal with the private sector easily. And I think that that's short-sighted, but it's also created this outsized power for the private sector. And then secondly, I think when we are contracting with the private sector, it needs to be, and incorporating them within any kind of decision making, it needs to be on a principled basis. And this is something that Section 27 and civil society in South Africa called for in relation to contracting of the private sector to provide services during COVID. It needs to be equitable. We need to make sure that people are receiving the services in an equitable manner, that human rights considerations are taken into account, that there's transparency, that there's public participation. It's only by doing that that we can harness the resources of the private sector in the real interests of everybody. But if we are going to allow them to be part of all decision making, be contracted and essentially name their prices, we're never going to get the equitable access to healthcare.
Thanks, Sasha. So to pick up on some of the themes, Sasha, that you've mentioned, but also Dr. Eckbold, David, when you spoke about the NHS, one almost gets the sense that people feel that government has not only abandoned the NHS, but also the people. So in that context, what steps, what concrete measures would you suggest government needs to take to restore stronger accountability, particularly stronger accountability in the health sector, and how would these contribute to rebuilding people's trust in the system?
Well, I mean, political problems require political solutions, and we need to think about how we can strengthen democracy and accountability of government and get better government. And this is why I ended up with New Zealand and Jacinda Ardern, because she really represents a style and form of governance that is so different from what we experience here and in many other countries. And what we need is to be able to emulate and replicate that style of governance that we see in New Zealand right now. I also want to come back to this idea of social vaccines, and to pick up on what Sasha said. Social pathologies, let's think about social vaccines, and regulation is clearly one of them to kind of correct the problems we have with corporate influence and undermining of the democracy that we have in different countries. Regulation is one. The other social vaccine must be tax. We must be thinking about tax as a public health instrument that can help to foster redistribution of wealth and power, but which can also generate greater levels of public revenue so that we can fully fund and properly fund our public services and public institutions. So those are two concrete recommendations I'd make.
Thanks, David. So we have space for one more question, which will go to Peter. Peter, how do you think governments can ensure that they give due regard to scientific expertise, socioeconomic and cultural aspects of managing the pandemic, but also demonstrate global solidarity without adopting an entirely technocratic approach to the pandemic? So I suppose how to balance the scientific expertise with the need for widespread consultation and democratic participation at all levels. And how do you see WHO's role in this? And perhaps also, does that role differ in the global north versus the global south?
Some really interesting elements in there. Let me just say this. Firstly, I'll start with the practical thing, WHO's role. WHO is helping to lead the Global Action Plan for healthy lives and well-being. And we very much value the participation of civil society. We have a civil society and communities accelerator. So anyone who would like to reach out with criticisms, with suggestions related to the Global Action Plan, please do that. And I put my Twitter thing on the chat at Peter A. Singer, or singerp@who.int. So that's just a very practical thing. On your North versus South issue, I actually think COVID turns that on its head. Some of the best performers are so-called developing countries. And that's because of the muscle memory that they have in relationship to contact tracing Ebola, et cetera, the previous experiences with SARS-1 in some cases. And so I think one of the interesting things about COVID is it turns our rich country, poor country narrative right on its head. And then finally, in terms of the social issues versus the scientific issues, I do think COVID shows how important the blend is. So in my remarks, I tried to emphasize that actually the bedrock of the response is the global solidarity. And that's a soft value. Interestingly, when you look at the correlates of mortality rate, it's probably not capacity alone, like IHR capacity. It's probably not health systems alone. And the closest correlate actually seems to be trust. And the relationship between communities and governments, the leadership of leaders at all levels, from communities to heads of state, I think really is at the core of the successful response. So there's just some reflections on the point you made, and at a very practical level, WHO is very open to engagement with civil society, with communities, recognizing the importance of these issues. And I'd be very happy to engage with anybody on the panel, on the call, et cetera, to hear your ideas and your critiques. And so very much welcome the opportunity to participate here. And thank you very much, Lauren. I do feel a little uncomfortable that you keep calling me Dr. Singer and I keep calling you Lauren. So could you please just call me Peter before we end, so it redresses any type of perceived power imbalance there? Thank you.
Thanks, Peter, for a concise answer to a big question. And I think, what emerges strongly from all of the presentations is that civil society has a vital role to play in formulating policy and contributing to pandemic management, but also not just in the sphere of COVID, more broadly in exercising the right to democratic oversight over their governments, and that's a key part of what it means to have trust in government. So to trust that there's an institutionalized forum that will take your voice seriously and respond to it, but also to have not just the trust, but the knowledge that there's an infrastructure, public infrastructure, that will give you access to the forms of care, in this case, healthcare, that you need in order to live a good life, in order to live a life where you can flourish. And so I think that emerges very strongly. The other thing that emerges very strongly is that that's impossible if you only have a COVID vaccine or an HIV vaccine or a TB vaccine or a malaria vaccine, that you need a social vaccine. So to address some of the enduring structural inequalities that make a healthy life virtually impossible for some. And increasingly, that's something that's a reality also in the so-called developed or global North countries. It's not only an issue in the global South. And I think that also came out of the presentations very strongly. So thank you to all the panelists. The PMAC Secretariat would very much like all of the participants, the attendees in this session, to fill out a short survey at the end of the session. And then also I've been asked to announce that the next webinar will be on the 11th of November at 8 p.m. Bangkok local time. And its focus is on the socioeconomic impact of COVID-19 from an equity perspective, who is being left behind, and lessons for the future. So again, something that ties quite closely to the themes that we discussed in this panel. So thank you again to all the panelists, and good evening, good afternoon to you wherever you are. Thank you.